Hello, good morning, everybody. It's not, well, there we go, okay. Good morning, I'm Mark McInerney. I'm the Emergency Preparedness Manager for the City of Takoma Park. Welcome to our Opioid Awareness Summit and Emergency Preparedness Fair. As you can see from this morning, there's a lot of activity going on already. So we have a morning and afternoon of great content. We'll start things off with our 10 a.m. panel. Happy to have all of our panelists on board here. I just want to say when we're done with this session, we do have the Montgomery County Police Department COPE trailer. It's a really great interactive experience. You can go right outside these doors on Grant Avenue and basically tour a typical home environment and learn about how you can spot potential risks of drug use, substance abuse in the home. It's a great way to kind of get some more information and strategies on how to prevent this in your household. But also, the fair has all of our partners from around the region with great resources, not only for substance use disorders and everything related to the opioid crisis, but also how you can be more prepared in any emergency. So thank you again for being here, and we'll get started. Thank you, Dr. Barton.
Can everybody hear me all right? I can use it if you'd like me to. Okay. All right. So I'm going to start by saying welcome, everyone. I'm Dr. Barton. I am an Assistant Chief of Police with Maryland National Capital Park Police, Prince George's County Division. And the first thing I want to say is I am excited to be here. All right. I'm usually walking all over the room, but I think I can stay put for right now. All right. I want to first thank Takoma Park Police and the City of Takoma Park for hosting the 2026 Opioid Summit and Montgomery County Emergency Preparedness Fair, raising awareness, taking action, and saving lives, right? I want to additionally thank the Montgomery County Office of Emergency Management and Homeland Security, Montgomery County Department of Health and Human Services, Maryland Office of Overdose Response, MORE, and Tree of Hope. I love all those words. Tree of Hope. Opioid Response. I love that. Let me ask you guys a question. How many lives would be saved if we treated addiction as a health condition instead of a morale failure? I want you guys to think about that when we get started, right? It's about families doing their best to hold one another together, neighbors who show up for their neighbors when someone is struggling, first responders, clinicians, peer supporters, faith leaders, right? And the community members who carry stories they don't always get to share. Opioid harm does not live in a particular zip code. It's not for a particular group of people. While the summit is rooted in awareness, it is really about something deeper. Compassion without judgment, choosing care over assumptions, and recognizing that behind every struggle is what? A human being and their family. Being here today is an act of hope, so thank you for being here. It signals that we're willing to listen, to learn from one another, and to respond with empathy, dignity, and responsibility. We don't move forward by pointing fingers, we move forward by extending hands. So, as we begin, I invite you all, no matter the role that brought you here into this room, to remain open, to listen, learn, and share with your neighbors. Of course, that would happen in the middle of something. I apologize. I had it on mute. I don't know what happened. Technology, I'm 59 years old, so I get that pass, if you know what I mean. So, a little bit of housekeeping. Turn off your phones. All right, with that said, I am going to start the panel discussion. And I'm going to start off by telling you a story. this may hit close to home, right? Football player, quarterback. We have a lot of those, right? Could be a family member. Well, this young man, he got hurt pretty badly. And he went to the doctor, he had his surgery, and he got medication. He got pain medication, some good stuff, some Oxy. Everybody know what Oxycodone is, right? And you know what fentanyl is, right? I don't want to assume. So he got the medication, and the football game, the season ender, everybody is, oh, we're going to win, but our star player is hurt. So weeks coming up to the game, he ran out of medication, and he was still hurting. He went and found it somewhere else. So those synthetic drugs that are on the street, and the kid overdosed because he wanted to please his family and the community. He couldn't let them down, right? And they were having a party, and he overdosed. And the fear at the time was, oh my gosh, if we call 911, we're going to get locked up. Because they're all underage. There was drinking, things like that. And he passed away because they cleaned up the area before calling the police. When we are called as police officers in these circumstances, there's a thing now in place called the Good Samaritan Law. Is anybody familiar? So, you have the Good Samaritan Law for CPR and first aid and all of that. They went a bit further. So they have a specific Good Samaritan Law now for opioid overdose situations. When an officer is called, they're not allowed to take any law enforcement action. They're there to save that person's life. So there are 6 crimes that will not pass if an officer gets to the scene and someone needs help, right? So the fear is gone for the person calling. The fear is gone for the person who is going through that crisis, right? We're there to save lives. So with that said, I am going to introduce you to the panel. Emily Keller is the Special Secretary of Overdose Response, the Maryland Office of Overdose Response, the MORE, right? Can you tell me a little bit about yourself and what you do?
Absolutely. Thank you. Good morning. Thanks for being here today. My name is Emily Keller, and I'm honored to serve as Maryland's first Special Secretary of Overdose Response for the Moore-Miller administration. I oversee Maryland's Office of Overdose Response, which the acronym is MORE. That was not intentional for our governor, but just so happened to work out that way. When Governor Moore was elected, he decided that he wanted to have a cabinet member that reported to him and attended cabinet meetings specific for substance use. So I'm thankful to be here. I've served in this role for about 3 years now. So at Maryland's Office of Overdose Response, which was formerly the Opioid Operational Command Center, we work with all the state agencies that have a hand in substance use and coordinating the state's response, and we publish the state's response to overdose response each year. We also work with all 24 jurisdictions. So we have overdose prevention teams, or OPTs, in all 24 jurisdictions, and we help coordinate, help with best practices, answer questions, and just make sure we're all kind of singing from the same sheet of music, if you will. We are focused right now on 5 priority areas, which are treatment, recovery, harm reduction, prevention, and public safety. And we think if we go about approaching the overdose epidemic at all encompassing from all areas, and we're all on the same page, that we can make progress. And we've seen great progress. Last year, we had a 28% decrease in overdose fatalities. We've actually had a 53% decrease in overdose fatalities since our highest in 2021. This is incredible progress. We went from having around 10 Marylanders a day that were dying to right now about 3 to 4, which is 3 to 4 too many. Because while we talk about numbers, and we should be proud of the fact that there has been that 53% decrease, every life lost is one too many. And at Moore, we believe that every overdose is preventable, which is why we're focused on those 5 key priority areas in making progress. Something else that we oversee right now is the Opioid Restitution Fund. That's the prescription settlement lawsuits from the pharmaceutical companies who really got us here in the first place. And if you guys have read any of the transcripts or seen any of the trials that are now public, we were lied to. The pharmaceutical companies knew exactly what they were doing, and they lied. They knew their medicine was addictive. They continued to market it as non-addictive, and now hundreds of thousands of lives have been lost. So the settlements ensure that they are paying to help combat this crisis that they created. And our office oversees that entire fund. Right now, Maryland, over the next 18 years, is set to receive about $600 million of that, and that continues to grow. Thankfully, our Attorney General is still fighting and settling cases. 70% of that money comes directly to you guys. It comes direct to the municipalities and the counties that were involved in the settlement. The state, we oversee 30% of that, 15% of that we offer back out in grants, and then 15% of it is used to support programs that we are supporting. So this is a really monumental time in Maryland. It is a significant amount of money, and if we are very intentional and focused on where we're putting it and making sure that we're supporting evidence-based programs, we can really see generational change. So those are two of the really important things that our office oversees.
So I wanted to ask the audience a question. Can you tell me or guess approximately how many individuals die each day from an opioid overdose? In the country. Each day? So I will share with you. Between 200 to 300 individuals die each day. So you're looking at 110,000 annually. That's a big number, right? And that's why this is so important.
Yes. And like I mentioned, those are our loved ones. Those are our friends, our families, our sons, our daughters. In my case, it was my best friend. I think we all now have a personal story of someone that we've lost. And we really just want to humanize this, because people who use drugs look like me, they look like you, they look like anyone. And it can happen to any of us. And it's not a moral failure, like you said. I mean, we're all humans. We're all living life for the first time, right? And anyone can end up in that situation. So we are just trying to eliminate that stigma and say it's okay. It's okay to not be okay, and it's okay to ask for help. And if you're not ready for help in this moment, we still want to be there to support you through harm reduction efforts and to make you feel and be as safe as you can be until you're ready for treatment. No one wakes up, in kindergarten, first, second, third grade, and writes in their diary that one day they want to have a substance use disorder and destroy their body and their lives and break the hearts of everyone around them. No one does that. But we could all be there one day. So it's my job and it's our job to let people know that it is okay and that it will be okay, and we're going to support them through it.
And let's bring it a little closer to home. Many people look at addiction like it's their problem, it's not mine. It doesn't have to be someone that is an addict, right? How many of us have a surgery on a regular basis? Any family member? Oh, let me ask an easier one. Been to the dentist lately? Had to get that root canal done? What kind of drugs they give you? What they're doing now is anyone that's had major surgery is now being sent home with Narcan. The doctors are being held responsible for those things, right? So now, if you're taking that home, you also are getting Narcan, which I know we're going to be teaching a little bit about using that moving forward. So those are just some things that I want you to think about. It doesn't have to be someone who is completely addicted to something. It can be an accidental overdose. So also make sure you lock up your prescription medication. A lot of people who are in stage 4 cancer take what? Fentanyl, right? And they come, if you cannot swallow, they come in a lollipop form. If you don't have that locked up and you have a young one in the house, what do you think will happen? And that's an overdose. So a part of this is just awareness. So I'm going to move on, and I am going to introduce Zachary. Zachary Stansbury is the program manager, Prevention and Harm Reduction Services, Behavioral Health, and Crisis Services in Montgomery County Department of Health and Human Services. Can you tell me a little bit about yourself and what you do?
Yeah, good morning, everyone. My name's Zach Stansbury. I'm the Prevention and Harm Reduction Program Manager. Currently, I am administrating most of the harm reduction efforts across the county, so that could include syringe exchange programs, it can include harm reduction vending machines, and it can include Narcan saturation throughout the county and Narcan trainings throughout the county so that the community is more prepared to respond to potential overdose events.
So who can take, so, me and this mic, who is allowed to take those classes?
Anybody's allowed to take those classes. You can sign up online. Pickupthepieces.moco.org is our new website that's rolling out so that you can apply for an online virtual training, or you can watch a video and then provide your mailing address and we can mail you a naloxone kit as long as you're within the county.
So the biggest question is, how much does it cost?
It's free. Narcan is completely free. As long as you come to one of the overdose response programs or you reach out to like DHHS or the fire and rescue or one of the other providers throughout the county, you'll be able to receive Narcan for free.
That's pretty awesome. How do you approach conversations about harm reduction with the community, like stakeholders who are skeptical?
Yeah, that's a great question. I think that the most important thing to start the conversation is to reframe what progress may look like for individuals who are engaging with recovery. So when I think about talking to stakeholders that may be skeptical within the community about what harm reduction looks like for individuals, I really want to stress that harm reduction is meeting individuals where they are in their own journey of recovery. It's helping individuals define what recovery looks like for themselves and helping guide them through all the potential ups and downs throughout that journey of recovery that they're undertaking.
That's awesome. That's awesome. I'm going to introduce Ben Stevenson. Ben, can you tell me a little bit about yourself? I see here that you're the manager at Prevention and Harm Reduction Services for Behavioral Health and Crisis Services in Montgomery County Department of Health and Human Services. So can you tell me a little bit about yourself and what you do?
Sure. So good morning, everyone. Happy to be here with you. So I'm Ben Stevenson II, and I usually say the second because there's actually two Ben Stevensons with Montgomery County, names spelled exactly the same.
Okay.
But I'm the manager for Prevention and Harm Reduction Services within the Department of Health and Human Services. So I oversee all of our substance use prevention, education, and awareness efforts within the county, in addition to our harm reduction services. So work in collaboration with Zach. Also work in efforts to reduce suicide, do suicide prevention education as well. So under my purview, there's quite a few programs under prevention. So we do a lot of coalition building, a lot of efforts to empower young people to use their voices to educate their peers about the dangers of substances, about the importance of mental wellness. We also do a lot of work around raising awareness around substance use. So we do a lot of community awareness campaigns. And then just like Zach indicated, under my purview is the Narcan training and distribution program, the syringe services program, and then our efforts to distribute fentanyl test strips, xylazine test strips, and things like that. Zach and I are actually working in collaboration, trying to deploy harm reduction vending machines. So currently we have Narcan kiosk within the county, dispersed through different places throughout the county. And then we're also also support the administration of opioid abatement funds within our OPT. So I sit on that committee as well.
So you said you have the distribution vending machines, so to speak.
Yep.
Where can they find them? Like what stakeholders, what partners do you have that's supporting that?
Yeah, so it's some of that stuff is actually kind of happened organically through collaboration. So our Department of Corrections wanted to host vending machines in their lobby for when visitors come and things like that. So we have one at MCDC, which is 7 Locks Road. There's one up in MCCF, which is up in Boyd's, Clarksburg, Maryland. We have one at developed a partnership with a local gas station owner. So we have one at a Sunoco gas station off of Cherry Hill Road in Silver Spring. And then we also just put one at in our lobby at our MAT program, because we were like, even though persons might be in MAT, they may still know people who are struggling and things like that. So them being able to grab a box of Narcan easily, we wanted to make it accessible. And currently we're also exploring other avenues like libraries and other spaces to put them to.
So a big one for me is churches. Are any of them in any of the churches?
We don't have any at churches, but we do have a lot of partnerships with churches. So we go into a lot of different church venues and do trainings on a regular basis. And then a lot of our church partners actually invite us out because they do like wellness events. So we'll go out there and set up a table and just distribute Narcan and do like the rapid training versus an actual like large training. Yep.
Okay. Absolutely.
I also just want to add, the Lieutenant Governor chairs a faith-based coalition through the state, and one of our initiatives that we've done, we work directly with her on our issue. And we held a faith-based summit last September. There were about 150 people there, and we convened faith leaders from across the state, mostly focused in Baltimore City to start. But we had really good conversations, panels like this, on what that looks like in your house of worship. There's a lot of stigma, and it was refreshing because they were admitting that and saying, like, we just don't know how to help. We want to help, but we don't know how. A lot of them have turned away harm reduction programs, syringe service programs, because they were scared, because they didn't understand how it helps improve the health of their members. So we had some really good conversations, and there's some follow-up happening on that right now. We want to make it a statewide initiative because faith-based communities reach folks that I can't, that they're not going to. And so engaging them and having them involved in this process is a huge deal, and we're thankful for the partnerships that we're building there.
That's awesome. That is awesome. I did have another question, just actually observation. Are you guys familiar with, I believe it's 988?
Oh, yeah.
You want to talk a little bit about that? Because it's connected to
Yeah,
the
sure.
suicide prevention.
Sure.
And
So 988 is the hotline that anyone can call, text, and reach a licensed clinician just to talk through if they're dealing with things related to mental health. There's also been a push to make sure that there's staffing at that line for a person who might be dealing with substance use challenges as well and may need to get connected to resources. So I know our partner within Montgomery County, Every Mind, is like the hotline host within Montgomery County. And we do a lot within DHHS in regards to just kind of educating about that resource and getting people connected. So it's definitely a great resource to utilize to get connected to services. And then we also, of course, have our crisis center as well, which is 24 hours a day, 7 days a week.
did you hear the number? 988.
Yep.
All right. I'm coming back to you, Emily. What is the biggest threat to overdose response in Maryland?
That's a great question. I think there's several right now that we should be concerned about. One is federal cuts. The federal government's approach to substance use disorder right now is very different than it has been in the last several years. The unfortunate thing about that is over the last several years, we've made the most progress. And we have made the most progress because we have focused on substance use disorder as being a public health issue and not a criminal issue. Criminalizing drug use just flat out hasn't worked in this country. It didn't work for 30 years. We can show that in stats, right? But treating people as someone who has a disease has worked. And so there's a lot of things right now, especially with harm reduction. Harm reduction, even the term harm reduction has been removed from SAMHSA websites, from federal websites. We're referring to it as meeting people where they are at. The reference of syringe service programs has been removed, but we know they save lives, even though they're controversial. And I think that's a real challenge right now, because I can understand, and I'm sympathetic in a way, to people who are scared of syringe service programs, right? It sounds scary. You're providing drug-using equipment to people. So I hear it. Like, I understand if that's all you know about syringe service programs, how that could be a concern. But when you actually look at the data and see the great things that it does, and that people are 457 times more likely to enter treatment if they are engaged with the syringe service program, that's a huge number, right? And so we shouldn't let our personal feelings, our personal, things that scare us get in the way of data. Also with Medicaid cuts, we all know, there's a lot of cuts coming down the pipeline really everywhere. And Medicaid is one of those things. And right now, Medicaid is the largest provider of substance use treatment in Maryland, because a lot of folks who do receive treatment, both mental health and substance use, have Medicaid. So if there are cuts there, where's that funding going to come from? We need to make sure that people have access to the services that they need.
And more importantly, they're going to, our families are not going to just sit there. They're still hurting. So they're going to go to the streets to get what's on the streets. And that is where the bigger problem occurs, right? Is everyone in the room familiar with some street names for some of these drugs? Ever heard of Skittles? That's for your kids that are in elementary school, near the playground. This is about awareness, right? They look like Skittles, but they're laced. Everybody in this room ever heard of a pill party? You've heard of it? So essentially what a pill party is, you're out of town for the weekend as the adult. Your young ones, teenagers, they're having a little extra party at your home. You left your medicine cabinet unlocked, and they put all of that together, every medicine you have in pill form, and they take it and see how fast they can get high. And that's when we get the overdose calls. That's when we follow the Good Samaritan law of go help that person, right? But lock up your medications, all right? Anybody want to share anything with regard to what they're seeing in the schools?
I can just, like, statewide, some good news that self-reported drug use, that's how we get data, because getting data from 18 and younger is very difficult. Even at 24 and under is still very difficult to gather. But we go off of self-reported data, and we have seen in the last 3-4 years that self-reported drug use has decreased in youth, which is a very good thing. Obviously, vapes, people are vaping, students are vaping, it's a big deal. But as far as taking pills and other drug use, that has decreased. With that said, Hispanic youth, we are seeing increases compared to their white and black counterparts. So we are seeing increases in the youth Hispanic community.
Why do you think that is? Did they have a reason for?
I think there's a lot of them. I think one of them is lack of resources, not knowing where to go. I think the current environment that we are in right now toward people who may or may not be documented citizens is going to probably make this worse, because people are going to be scared to reach out and receive treatment or ask for help.
You wanted to touch on that as well?
Yeah, just to kind of piggyback off of that, just thinking about like the social drivers of health, right? So looking specifically at lack of access to health care, lack of access to insurance and things like that for that population, where they might turn to the street to try to deal with whatever they're going with, lack of access to employment, to income, to food, healthy foods and things like that. So I think all of those play factors, are contributing factors in regards to increasing the risk levels of substance use. So if you're able to impact those risk levels with protective factors, providing those resources and things that people need, then it can lower the likelihood of them going down the path of using substances. And so that's the practice that we use in prevention, is trying to employ preventative or protective factors to try to mitigate a lot of the risk factors that our community experiences.
So for anyone on the panel, what is the hardest, what group is hardest to reach?
Well, I mean, this ties into exactly what he just said. Overall in the state of Maryland, 55 and older Black men are dying at a rate significantly higher than every other demographic. And Black Marylanders are dying 3 times the rate of their white counterparts. But 55 and older Black men, we are seeing huge racial disparities, especially in Baltimore County and Baltimore City. And that goes to everything that Ben just spoke about. Lack of access, lack of trust of the medical system, and rightfully so, lack of opportunity, and also now we're seeing cocaine is making a pretty significant comeback. I wouldn't be surprised if in the next foreseeable future we're seeing cocaine death rates equal to fentanyl death rates. And Black men over the age of 55 historically used cocaine, so now that we're seeing cocaine that has fentanyl in it, other things, it continues. So for us, as an agency and as a state, we're focused on how do we deploy resources into the communities and be where the people need treatment, because we can't expect everyone to come to us. We can't expect people who are skeptical of the medical system already to walk into a place and ask for help. We have to go to them. And there are some counties that are doing mobile outreach very, very well. And that seems to be kind of the up and coming thing, is going into neighborhoods in a van with a primary care doctor or a nurse, or harm reduction services, and providing treatment services right there in the communities, and allowing access in ways we haven't really done before.
And just kind of piggyback off that again, I don't know, it seems like you keep throwing me alley-oops and I can dunk it or something. So, so Montgomery County does have a mobile vehicle. Fortunately, our public health services has a mobile vehicle that goes around and is stationed in different places throughout the county, and they're able to provide basic medical care needs, whether it's dental, medical, things like that. And so, and then we've been able to, within harm reduction, kind of partner with them and kind of engage with persons as well. And then also, and I think Anne Arundel put out, has a mobile vehicle that has been able to become statewide to, introduce buprenorphine for persons who are interested in getting in treatment. So then they're able to connect them with their local provider and stuff like that. So I think collaboration has been a very big key for us. But just kind of going back to the conversation around harm reduction, I kind of feel like harm reduction only becomes stigmatized when you put a substance on it. So if you think about, if you go to the beach and you put on sunscreen, that's harm reduction. If you get in your car and you put on a seatbelt, that's harm reduction. If you go drive your car and you stop at a stoplight, that's harm reduction. It's helping to prevent an accident from you going through that thoroughfare. So only time harm reduction becomes stigmatized is when we add substances, and knowing that and understanding and having that conversation can normalize it so that people won't be fearful to come get help. It'll normalize the fact that, hey, harm reduction programs are there to keep people alive and keep them safe, to give them that second opportunity to go to treatment at some point in time when they are ready. They're the captain of their journey. We're just the supporter. So echoing that conversation is what we try to do in the county, just to let people know harm reduction is not enabling. It's not, giving people tools. It's trying to protect them and keep them alive and keep them safe.
It's treating them like humans, right? So you used a medication. I always say it wrong, bupe. For those who don't know, can you go into that a little bit about?
Yeah, sure. So buprenorphine is a opioid antagonist, which is a substance that's used to treat opioid use disorder, similar to methadone. And so a person can be prescribed buprenorphine as one of the MAT practices. They could also be prescribed methadone. Just all depends on what the provider provides and things like that, and feel is best for the client. They also have Vivitrol injections, which are like 30-day injections, because sometimes you can't count on people to take their medication on a daily basis. So giving a 30-day injection might hopefully, lessen or prevent those cravings for the opioid. Because I think just kind of going back to something else Lieutenant Secretary said earlier is that we didn't know how strong and how powerful these drugs were. We were told that they weren't addictive, and we learned that that was not true. And so understanding how much control these substances have over people lets us know that, you know, we're at risk with lessening of Medicaid and Medicare, because then they won't have the funds and the opportunities to get into treatment or to sustain treatment because of the lack of resources. So, yeah, I think just making sure that we continue to fight the good fight and support persons that are struggling is just the most important thing, and it's an all hands on deck type of approach.
Go ahead.
I just think it's important too to have just a quick, larger conversation about medications too, because there is a lot of stigma around medications. There's a lot of stigma around people who are on methadone or on buprenorphine, and medications are the gold standard for treating. It is a disease. Substance use disorder is a disease. If you have a heart disease, you take medication. If you have diabetes, you take medication. If you have a substance use disorder, you take medication. And the long-term health outcomes are generally so much better than for someone who's not on medications. And I know that there are programs like NA and AA historically has not been friendly to people who are on medications because they consider you not abstinent. They consider that another drug. And I hear it all the time. I'm sure you guys have heard it. Well, you're replacing one substance with another. No, you're replacing an illicit substance with a medication. There's
So
a big
where's
difference.
that conversation going now?
Yeah, I think we are starting to turn that tide. Just like stigma with substance use disorder, it's still there, but we're getting better. We're getting better because we're having things like this and we're talking about it and we've humanized it. And I think that's the same with medication. We still have a lot of work to do and a lot of education to do, but there are more opportunities to receive medications now. The mobile health clinics, doctors, physicians are able to prescribe it. Medications are now given in jails in Maryland. Every single jail, if you have a substance use disorder, they provide you treatment. It's a huge deal. It's a huge deal. So we're getting better.
That's good. And on that same line, I want to throw this out to anyone who wants to answer. We know that we have individuals in our families that may be going through that difficult time, but what kind of support is there for the other family members? Is there anything that's in place that they can get that type of support? I know you can call 988 if you're struggling with just dealing with a family member that's having that problem, but are there other things that are out there?
I know there's quite a few like support groups within the county and even statewide that people can access and just have like a listening ear and things like that. I know one of the strategies that we implemented with our opioid abatement funds, because we saw young Latino and Hispanic youth struggling with opioid use disorder and things like that, was the initial population that we recognized, but then, of course, wanting to engage in other populations. So we started a substance use prevention intervention program with one of our community partners to engage with young people as young as 11 all the way up to 25 that might be struggling with substance use, building those relationships, helping us connect so we could provide those harm reduction supports until they're ready to go to treatment. While when they get them connected to a residential program, they're also working with the family, supporting the family around addressing any additional needs, because at some point in time that young person is going to come back home and they want to try to put some protective factors in place. So I think that's just one program, but I know there's quite a few other programs in the county that are supporting the family in addition to supporting the person that's struggling.
Yeah, because that is so important, right? If you don't have the family support with some understanding, they're going to be, like you said, look at it as, oh, they're an addict, or they don't understand that this is also a condition. I am going to, because I know we're getting close to time, I'm going to throw it out to the audience if they have any questions for any of the panel members. Yes?
My name is Guillermo. Very easy for you guys sharing to us that I will ask, with all the experience that we have in what means, addiction, whatever type of addiction you have, during all this time, how do we get to the point that right now, at this moment of, our year, what do we learn? How steps do we need to take so we don't have to suffer for say something? Housing is short, right? Help is short.
Yeah.
So you guys who are in the panel, and you lady who is part of the addiction crisis that this county is all about, what do we learn during the process?
Jonah.
I think we've learned a lot. I think we learned a lot in regards of, how to engage in various communities, right? So I think at some point in time there was a lot of silos that were taking place where a lot of people weren't communicating with each other. There were a lot of views as, hey, this can't happen to me, right? And then if it did happen in that community, then there was a direct connection. So we were able to build those relationships to try to prevent the next person from going down that path and struggling. I think when it comes to substance use disorder and opioid use disorder specifically, we've learned also that not everyone is going down the path of experiencing substance use disorder by chance. Like, a lot of this is related to a lot of those social determinants of health and other factors. So if we can impact those other factors, like you mentioned, like housing and healthcare, the food supply and all those different things, can hopefully help us impact substance use as well, because you're building. We learned that if you build up those protective factors within the family unit, but also within the community, then you can hopefully build up morale within the community and lower and lessen the chances of persons going down that path of substance use.
I think we have also learned, too, that this doesn't go away in 28 days. If you go back 10 years ago, we get someone into treatment, you go away for 28 days, you come back and be like, oh, cool, you're fixed. And that doesn't work. Substance use disorder is a chronic relapsing disease. It's a lifelong disease. And so we have to treat it as such, which is why, like, some of our focus is recovery friendly and making sure that employers know what it means to be recovery friendly, that we have support systems across the state for people who are in recovery, who need to attend a meeting if that's what they want to do, or need to be around people and have sober environments, things that they can do. That's very important. And it took us a while to really, I think, wrap our heads around that. And then it took even longer to put funding behind it, right? Because you have to have money in order to create programs. And for so long, we were like, okay, go to treatment, and then everything's going to be better. Well, your brain hasn't even healed yet. You may have been off substances for 28 days, but if you don't have food, if you don't have housing, if you don't have employment, if you don't have all of these other things, while still trying to heal what's happening to your body, you're not going to get better. So I think we've really learned that this is not a one and done thing. I also think we've learned a lot of lessons with, like, the criminal justice system and how we handle people who are using drugs. Because with all due respect to law enforcement chief, you guys have such an important role in this and overcoming this. But locking people up and putting them in jail and not providing treatment and my best friend before she passed away had violation of probation after violation after probation after violation of probation. She'd get 90 days, she'd get out, and within a week she was using drugs again, because that 90 days did not help her. She didn't receive treatment. She wasn't, working on herself. She'd get out and she'd use drugs again. And then the last time, she became one of the statistics of people who get out of jail, go back to their same use and overdose and die, because we weren't treating the person. We were just throwing them in a jail cell. And so I think we've made a lot of progress there, which now we have diversion efforts like LEAD, law enforcement assisted diversion, where you're taking someone who's a not violent offender and offering them a diversion program to get into treatment. We have problem-solving courts like drug court and mental health court. So if you're already involved in the criminal justice system, you can go to a drug court and go through a treatment program and really start working on fixing the core issue and helping the core issue of your disease. That also took a long time, and it took changing demographics and everything else to get here. So I think those lessons are really important and things that we're building on.
Yeah, and I think that over time, we are getting better, and we are doing better. And 3 things to note: we've become very transparent. We've identified that this is a problem. We're investigating through research and best practices. We're getting it done, and we have a plan of action. So we're implementing these things that's supportive of our community. And me personally, I take full responsibility for everyone that's around me, because that could be my sister or my brother, right? And I created a nonprofit called ICU Shine, and it's giving people second chances where they can get educated and do different programs like that. So those are some of the things that we're doing. The biggest piece for me is the transparency, because if you know how to deal with the situation. Any other questions?
I have a question, Dr. Barton. So it seems pretty obvious that over the past several years, the medical community doctors have been targeted pretty heavily by pharmaceutical companies to push the product to their patients. And personally speaking, over the past year in my family, having some safe, no problem, but surgeries involved that had medication. One was Tylenol with codeine, the other one was Oxy, I believe. Has that environment changed at all? Are doctors still being preyed upon by pharmaceutical companies? Have they seen a little bit of light in how they prescribe these medicines, with a little bit more discretion? Just curious how that environment has changed.
So I'm going to address the ethics piece, and then I'll let you guys take the more legal piece, because I'm not good with that part. So ethically, there are people who are on pain management, right? You would think that every doctor would check to make sure that this person doesn't have another doctor. So now they're putting some of those things in place, but holding someone accountable is being able to identify the problem. And I don't know if there's a system in place at this time where you can tell if someone has medication at one spot, if they can go somewhere else. So
thankfully we do. I think that was a loaded question, by the way. So there are like several things. Yes, the pharmaceutical companies are no longer preying the way that they were. I mean, Purdue Pharma hired 25,000 sales reps to go around the United States to sell OxyContin back, which is, why we're in these settlement agreements now. Yes. And marketing 25,000 sales reps. I mean, they were making so much money. And the doctors didn't know. I think a lot of blame got put on doctors. And at first, it wasn't they didn't know. They were being sold a medication that was supposed to be non-addictive. I think there have been a lot of laws put into place now. There's been a lot of training for doctors and people in clinical settings. So they're now aware of what the medications do, a lot of education that they have to give to their patients. I also hear, I think there's come a point where we may have swung the pendulum too far, because you hear people who have chronic pain or who go in to get surgery. My daughter just had 4 of her wisdom teeth cut out. They gave her 5 OxyContins. I appreciate that. She didn't need more than 5, right? But whereas before, they would have given a lot more than that. But there are people who are having major surgeries or have major chronic illnesses who are now struggling to get pain medication that they actually need. So I think there's a delicate balance between how do we stop people from developing a substance use disorder to are we hurting people now who are in pain. But I say that also in the state of Maryland, we have the PDMP, Prescription Drug Monitoring Program, that every doctor, when they prescribe something, it goes into your file. So doctors can see that other doctors have prescribe them, and it is going across state lines now. Because I'm from Hagerstown, Maryland. You can drive 10 minutes and be in Pennsylvania, 10 minutes and be in West Virginia, or 20 minutes in Virginia. And 15 years ago, people were doctor shopping, from one hospital to another across 4 states in a day. That can't happen now because of those accountability programs.
So my recommendation also is, if you're on pain management and you realize that your medication is running out because they don't stock them in the pharmacies anymore, it takes a day or 2 for it to come in. So you plan ahead for those people who genuinely are in severe pain if they don't have their medication. That I have seen. Any other questions? Go ahead.
How can we help our children to stop using drugs, or how can we help our family to support with people who has drugs?
Great question. Prevention?
Say that. So I think when it comes to the family system and the family unit, right, those conversations have to be early and often. So as a father of daughters, like, I've had that conversation about substances ever since they were 6 and 7 years old, about safe medication use, about, things like that, right? And as they've gotten older, those conversations have changed, and I've tried to, put them in positions. And I guess that's just because of the unique work that I do, and not every parent is going to be comfortable with having that conversation, right? So we try our best to educate parents and caregivers about how to have that conversation, how to open the door to make sure that they have a relationship with their child, that their child feels comfortable coming to ask those questions, right? So I think similar to how we put a lot of emphasis on academics and academic achievement and things like that, and wanting our kids to go to the next level, we have to also have those conversations about true things, substance use, about mental health, mental wellness, opening the door for those continuous conversations, but also, and I truly believe this, getting them involved in things, right? So getting them involved in positive outlets, whether it's a sport or art or something, or just a youth group that just, promotes positivity and things like that. So one program we have in the county is the Be the One Youth Ambassador program. And within that program, we recruit young people from all over the county, from middle to high school. We educate them about mental health. We educate them about substance use. We put them in positions to educate their peers. We have youth ambassadors that actually teach Narcan training. And so they've trained over the past 2 years about 700 students in Narcan administration and recognizing the signs. And so I think continuing to have those conversations early and often, and understanding that, hey, we all have to work together is important in trying to deter substance use. I think utilizing evidence-based programs within schools, starting at as early as elementary school, booster sessions in middle as well as in high school are important. And even, some of the things that go across to, like, your colleges and universities. I think it's just it has to be continuous, and it can't just be like, hey, we did this one thing and it was great, and now we don't have to do anything else. Just has to be continuous.
Yeah, and you have to have, again, I partner with a lot of different people, so we have mentorship programs where we have those conversations. My organization, which is Park Police, we do Safe Summer. And Safe Summer, the officers actually interact with the young people and develop that relationship so they can actually share. And we try to get rid of the stigma. It's okay to have that conversation. So we are very approachable with regard to just reaching out to the kids. We play basketball with them, and as soon as you play basketball with them, they'll start talking to you. So I have to say I'm proud of the fact that we have that program in place, because it does reach the young people.
So there's nobody to understand an addict like another addict. I can come to the doctor, but doctor doesn't understand my health, doesn't understand why I'm sick for.
Yes.
So my point here is saying, there's people in recovery like I am. How can I move forward toward the system?
Support? You want to take?
No, about, I work for, Tree of Hope. I'm doing service in Tree of Hope. We offer recovery or whatever. But my experience telling me is that you work with somebody who have the addiction problem, and you can relate it to that. You can identify with that because you've been through that. Mm-hmm. But when you go to an organization that doesn't have the foundation, that's what the problem is.
I agree. And some of our agencies, we actually have individuals who has been there, who have been who had an addiction problem, who now partner with us to have those conversations, because me not knowing what it feels like cannot talk on the same story as someone who has been there, right? So we have opened those lines of communication where we partner with individuals who are recovering, and they are very open. So I guess we would just have to find a location if that's what you're interested in finding.
Well, yeah. First of all, congratulations on your recovery,
Yes.
and thank you for sharing that. So peer support specialists, who are often what we call peers, I've said it a million times, I'll say it a million more. Peers are going to be our way out of this, because you are absolutely right. I can't talk to someone with a substance use disorder the way that you can. You're going to make connections that I'm not going to make. And that's so very important. So peers we're seeing pop up all over. My office is trying to get them everywhere. Baltimore City has a program where they have peers in libraries. We're now trying to pilot that across the state. We just invested with Opioid Restitution Fund money into peers in rural areas to try to get Western Maryland and the Shore covered in peers. Peers are in library or hospitals now. In a perfect world, I would like to see a peer support specialist everywhere, because that's truly those genuine connections. And our service programs have peers. That's why people who engage in those services are met with dignity and respect, and someone who has been there and has experienced what you're going through, and often just makes so much more genuine connection. So thank you again.
I was just going to add that I think peers are vital to this work as well, just because with that lived experience, like just like these, they can engage better than a lot of us, right? Also engage in the prevention work that we do, trying to prevent that next person from even going down that path, because they can articulate themselves in a way that I may not be able to do. And so one thing that we try to also utilize is young people in that space, because a 15-year-old can connect with a 15-year-old better than I can, right? But if they're saying the same message or portraying the same message, it'll be a lot more impactful. So I think peer recovery specialists and peers in general are definitely vital to the work.
Well, first I want to just thank the panel members for this discussion. And so my question is, though the focus has been, and rightfully and understandably so, on narcotics, opiates, what concerns you in terms of other drugs coming down the line, both from an emergency management or medical intervention perspective, that perhaps isn't getting enough attention, or that we need to focus on, that doesn't have amendable treatment like a Narcan?
That's a great question. I think our drug supply is ever evolving in Maryland. We have a program called RAD, the Rapid Analysis of Drugs, where we take syringes. It's a volunteer program for people who engage in syringe service programs. They can provide their baggies, their capsules, their syringes. We test it real time, so we get to see a big picture of what's actually in our drug supply in Maryland. We've seen xylazine and medetomidine, which are used in veterinary care. We are seeing pretty significant decreases in xylazine, thankfully, because that is adulterated with fentanyl and causes massive wounds up to amputation. It makes treating someone more difficult, because even if they want to go into treatment, if you have open wounds, you can't until that is taken care of. And sometimes that can take months, years, leading to amputation, like I said. So that's a concern. The rise in cocaine is a concern, because just pure cocaine, you don't experience an overdose like you would an opioid overdose. They call it overamping, and that looks different for everyone. If you and I use the same amount of cocaine, what feels okay to me may send you into like psychosis or anything. So that's a more difficult problem to solve. And alcohol. I think we forget about alcohol a lot. Alcohol is still, a significant problem in this country, a significant problem. And we don't talk about alcohol the same way we talk about illicit drugs at all. And so it's socially acceptable. And look at, what happened during COVID. Everyone laughed about all of us parents drinking wine and teaching our kids. And we had the socks that say, "Get mommy a glass of wine." And, we have like really just normalized it. And I get it, it's legal, but it still has, disastrous effects on your health and on your well-being and on the public that you're around, and drinking and driving and all the other things that come with it. So I think that that's always a concern that goes like kind of under the radar since we have socially accepted alcohol. But I think as that continues, the younger generation is not drinking. There's been a lot of decreases. Alcohol companies are losing a significant amount of money. I think that that's a good thing. Hopefully that trend continues. But I just think that that's a silent killer that we don't talk about a lot.
I think another really important thing when we consider this is just the idea of like polysubstance use, which is the intentional or unintentional use of multiple substances at the same time. So when we consider all these adulterants that are within the drug supply right now, and we consider the effects of like metamidine withdrawal for an individual, it can be really difficult to combat all of the various adulterants without knowing what's in the current drug supply and being really in touch with what individuals are experiencing as they may use substances. And I think it's really important to continue to test all of these substances within the community so that we can stay on top of what these emerging trends are. There's things that are happening across like the country. The Appalachians are seeing a rise in a substance called cyclorphine, which is a very, very powerful sedative as well. And the rise of all these additional adulterants make it hard for legislators to combat which ones need to be addressed in a way that prevents individuals from putting them into the drug supplies as an adulterant.
So one of the additional things that we're facing and that is a concern for law enforcement is, I don't know if you're familiar with, it's carfentanil. I don't know if you've ever heard of that. That is the more potent fentanyl, so to speak, and that is now being mixed in the streets with other drugs. And so identifying this makes it more difficult for us to address those issues because they're always mixed with something else. Anything that's on the street is going to be mixed with something else, and that's what's causing chaos right now.
Just if you guys are interested, if you go to stopoverdose.maryland.gov, which is our office's website, there's a dashboard. And the RAD data, that rapid analysis of drugs that I was talking about, is going to be on the dashboard effective this month, I believe. So you will actually be able to go on and click your county and see what drugs are there. And you would be very surprised. It's completely anonymous. The only thing we ask is, what do you think you're using? And it, not really what you think you're using, but it will list out all the different substances that are included.
And should you have an overdose or someone take something at home, 1-800-222-1222 is poison control. And if you describe what you have, when you're getting help there, they may be able to identify that as well. So that's something you should have in your phone at all times if you have children, because accidental overdoses happen, or you may take something or someone give you something, and if you describe that pill, they'd be able to identify that. So it's 1-800-222-1222.
Hi, I'm Nora, and I work for Identity, and we get the pleasure of working with Ben many, many times. But I do have a question for the panel, actually, too. First of all, on the prevention side, we are starting to see through our work, we run the substance use prevention and intervention program for ages 10 to 25 in the county. And we are starting to see more and more fourth and fifth graders getting involved with vaping, alcohol, and cannabis. And so with the prevention, I would just, we focus so much of our attention on the older adolescents, but the younger, they're starting younger. We also run a program to help OUD sufferers, and 100% of the youth that we have worked with started fentanyl use at the age of 11. And it was provided to them in middle school. So one question I have is, you know, we've had many conversations with our school district, but the parents that we work with know that their kids are getting drugs in school. The educators we've spoken to know that they're being distributed in bathrooms. And it doesn't seem that we're doing anything about it. So I just wondered what kind of conversations, policy conversations you've been having about this, because we can't be the only ones who've shared this before. So that's one question. And the second question is really around another trend that we're seeing is for the younger than 16, so 11 to 16-year-olds. We have not many, but we have a handful of cases where youth addiction is greater than all the supports that we're providing. So youth may have been incarcerated, youth have gone to treatment, and parents have really tried to stick with their youth. But it gets to a place where, unfortunately, we see a lot of single mothers who have to make choices about the youth who is has an opioid use disorder and her other children. And so they often throw that kid to the streets. And so, of course, legally, that parent has to still be the authority until they're placed in foster or another type of situation. But on the ground, what we're seeing is those processes take too long. And in the meantime, the younger siblings end up being harmed by the behavior of their sibling who is endangering their whole family's livelihood, their whole family's housing. Not to mention, sometimes the youth that I'm thinking about have all threatened physical harm. And we don't have a place for them in Maryland. We don't have like a residential facility or housing or a transitional housing facility that specializes in comorbidity with mental health and substance use. And so my question is, what are we doing to address that? Because we're just seeing just so many. And so the alternative has been that those young, mostly women, young women end up in trafficking situations. And, you know, it is heartbreaking. And we would love to see a solution come from the state.
Yeah, I appreciate that. And I agree we haven't done enough. And I think this is part of things that we have learned over the last, 10 years or so. It looks different. Treatment looks different, especially for kids. It also looks different for, adults with children. And, we've done treatment so often as a one-time fits-all type of thing. Like couples can't stay together. You can't stay with your kids. The kids can't be here. And I think for youth, we have an inpatient that they can go to for 28 days, right? But it's not enough. Yes.
Rarely.
Yes.
On average, our kids are staying only 10 days.
Yes. And inpatient might not be the most appropriate route for a young person because that's separating family as well. So is it outpatient? Is it housing? Is it like recovery housing for young people?
About a specific population, not to interrupt you, but I'm talking about the population of kids that are so in such dire need that the family can no longer, the family is being harmed as a whole. Other siblings are being harmed. That youth is harmed, is in a harmful situation because they keep returning to the very situation that put them in the addictive cycle to begin with.
Yeah.
And there is no other place to place them because we don't have group foster care, and we don't have foster care for a child that is experiencing SCD or OUD. And so we cannot eat them, we cannot put them in children in need of special supervision because none of those programs accept them.
Okay.
And I'm not talking about the kids that it's normal, like we're talking about the tier 3 kids. The tier 3 kids that are really suffering because we have had a handful of kids, and unfortunately last year, or in July of last year, we had one of those situations where we lost a youth. And and I just are bringing it to you as a concern.
Absolutely.
Because it's not about, do we have enough continuity of services from the inpatient to the outpatient model? That's not what I'm saying. I'm saying these are kids who literally can't live at home because their parents don't know what to do with them. They keep running away. They have physically threatened their parents. We go to police. Police can't do anything because it's a substance use disorder issue. It's not, in some cases, it's not a mental health issue, or it's a psychotic issue that is happening as a result of the use of the drug. So it is not considered the same way as if they were in psychosis. So we have had to advocate over and over and over and over again for inpatient treatment at psychiatric centers and residential places, but that's not the appropriate placement for that child either. And so we're asking, could we come up with an alternative for housing? For, I'm not talking all youth, I'm talking about the very small handful of youth that are actually a problem for everyone, because then they go out on the street and they are committing crimes because they're being driven by their need to find drugs, right?
Yeah.
Or they are putting themselves at risk, which happened with our young person who died. And they are then become victims of violence because their pimp, their trafficker, and they're 15, they're 14, they're 13. We're not talking about 21-year-olds. We're not talking about 30-year-olds. We're talking about 14-year-olds. And
kids.
that's the population I'm asking for help for.
Yeah, and I would love, maybe we can connect to get the partners at the table. My office doesn't implement programming, we only support. But I could, the people that need to be at the table would be like the Behavioral Health Administration, Department of Human Services, Department of Juvenile Services. I'm more than happy to convene a meeting to have that discussion further. Because I agree with you, there's a lot of areas with youth where we're missing the mark, and that's concerning, and I would love to help. So if we could discuss and make sure that the right people are in the room on that conversation.
And I absolutely can, I hear you. I see you, I hear you, and those are conversations that need to be had, because the more aware we are, the more solutions we can come up with. So it's about partnership, networking and partnership, understanding the needs and addressing them. So thank you for sharing that.
If I could just go back to your first question too about education in schools, because this is like something that is, I'm very passionate about this subject, and I thought in my prior role, I lived in Hagerstown, I was the mayor of Hagerstown, and I worked and started up Washington Goes Purple, which was an education movement, and our whole mission was to go into schools, and we wanted to be in elementary schools, and we wanted to be, and the county politics are significantly different in Washington County than in Montgomery County, but we fought a lot of resistance. And so when I took this role with the state, I was like, yes, I'm going to go in and change it. Right? The way that Maryland's curriculum is set up is MSD, the Maryland State Department of Education. They require drug education in schools. The counties have to meet a mandate. The counties get to decide how they meet that mandate. So it's a box, they have to check it. It has to be evidence-based in some form, but that's it. And then the state level MSDE can just says, okay, great, you did the drug education there. They cannot dictate at this time, they cannot dictate what exactly is being taught and what that looks like. So while drug education in elementary school in Montgomery County could be very good or it could not be, you can go next door to the county next door and it would look very different. And you could go to Allegheny County and it would look even more different. And that's something that I would love to see change. We have advocated for how do we get evidence-based practices in young elementary schools? Because I know that I've talked to parents who cringe immediately. And it's like, we're not going to talk to a third grader the same way we're going to talk to a 10th grader, but we still have to talk to the third grader. So I'm big on advocacy. I would encourage everyone who's passionate about this subject to reach out to your legislators to see if we can all work together to implement that change, because the change absolutely does have to be legislatively mandated. It would have to go through the legislative process in order to be more specific as to what is being taught and when.
And I know that we are just about out of time, but do you guys want to say something from your team so we can wrap up?
I was just going to share that I do know Montgomery County is in the process of going to do an RFP process to try to identify a provider or organization to implement evidence-based curriculum for upper elementary, lower middle school. So I know that that's coming down the pike soon. Utilizing opioid abatement funds, of course. And then I know there's this hub process that's happening as well with a lot of providers that are looking to implement evidence-based programs within schools and different spaces and things like that. So I think that's a partnership between like DHHS and MCPS. So I know that that's coming down the pike as well. So a lot of things are working. It's just kind of, it's just sometimes things take time to get up and running, but it's coming.
Hi, I'm Laura. I'm a registered nurse. I live in Baltimore. I have a question for Ben. I think this is a really, really valid question, concern I didn't know about. But I wonder, sort of on a smaller practical level, how can you give us an example of those conversations you had with your kids? Like, what does that look like at a smaller level?
Sure. I'm gonna tell a story really, really fast because I could get long-winded. But I remember when my wife was giving birth to my second child, right? And we were leaving the hospital, getting into the car, and my oldest daughter asked my wife, "Mommy, have you ever smoked weed?" And me being the prevention guy, I'm like, "Oh God, we got to have a conversation. I need to pause. Let me figure out. Let me get my bearings together." And so luckily I had access to resources, and we got online and saw some little videos and games and things like that. So I tried to make it interactive. And I just basically, laid it all out for her. I told her what, our expectations were as parents. But I also opened the door like, hey, if you ever get in a situation, like, we want you to come to us. We don't want you to be fearful, like, hey, I'm going to get in trouble. Yes, we're going to talk to you, and we're going to be firm in our stance, but we just want to make sure you're safe, because I try to tell her now, and I try to tell my kids now, since even if they're older, that the mistakes that a lot of us older adults were able to make, they can't make now, because that mistake is taking people's lives. And so just trying to equip them with as much knowledge and not using scare tactics. I think scare tactics is one of the worst things you can do. You just be factual, stern in your stance, and supportive, and let them know that you're there, and making sure that conversation is just continual.
I would have that courageous conversation, and don't allow outside to teach your child before you share that information with them. Don't be afraid to talk to them because they're going to know about it from somewhere. You want them to have the right information, so start early.
Great. Hey, let's round of applause for our panelists, please. Thank you so much, everybody. And thank you, Dr. Barton, for moderating. So this concludes this panel. I would encourage you all to go outside, visit the COPE trailer, and then we'll get our naloxone training underway shortly in the hydrangea room, which is just across the atrium. If you're interested in that, please check it out. And then we'll be back here at right around 12:30 for a discussion, another panel on peer recovery workers, clinicians, and that whole other side of this very large subject. So thank you so much, and we'll see you back here.